Hi friends, today I will talk about the snake bite management part 2. In the part 1 I discussed about the various types of snakes, their toxicity, their presentation and the first aid which is to be administered in case of snake bite. In this video I will be discussing the management part which includes administration of anti-snake venom, its complications, its adverse reactions. First is the disclaimer. Caring Dogs YouTube channel does not provide medical advice. Information available on this channel does not offer diagnosis or advice regarding the treatment. Information provided by this channel is for educational purpose only, and information provided here is not to be used as an alternative to healthcare professionals' diagnosis or treatment of any person or animal. Please seek the help of medical expert for diagnosis, prevention, and treatment of medical illnesses. There is no endorsement for any brand or company. Coming to anti-snake venom, let's discuss some interesting facts about venom. We should always remember that snakes they do not exhaust their venom store even after several bites. Larger snakes they inject larger amount of venom than smaller specimen of the same species. Younger vipers venom may contain dangerous component which affects the hemostasis. Same amount of venom may be injected in both adult and children. Bites by the small snakes should not be ignored or dismissed. They should be taken as seriously as bites by the larger snakes of the same species. When to start treatment? Do fang marks matter, or we have to see the features? It has been seen that we don't start treatment on the basis of fang marks because these fang marks may be dry bites, as a snake might have bitten the person but the venom has not been injected, or these bites may be because of non-venomous snakes. So we have to see the clinical features like vomiting, abdominal pain, bleeding tendency, which are seen with Vipridae family of snakes, ptosis, ophthalmoplegia, neuromuscular weakness as seen with elapid and Russell viper, myalgia, stiffness, tenderness, trismus, myoglobinuria seen with the sea snakes and some crates, and renal failure seen with humped nose bit viper, saw-scaled viper, and pituitary and adrenal insufficiency, though is a late complication of Russell viper. Snake identification is not important because in this picture we can see common crate and common wolf snake. One is poisonous and other is non-poisonous, and they resemble with their physical appearance. So there is no simple rule for identifying a dangerous venomous snake. At times some harmless snakes have evolved to look almost identical to venomous snake. We cannot decide that with the fang marks that it is dangerous bite or not, because fang marks or their pattern have no role to determine whether the biting species was venomous or non-venomous, or amount of the venom injected and severity of the systemic poisoning. Elapid or Vipridae venoms, some species like crates, they may leave no bite marks. So we have to not only depend on the fang marks for the treatment, we have to see the clinical features of the bite also. Local findings at times are helpful, and at times uh, local findings in the form of swelling, cyanosis, lymph node enlargement, blister formation, conjunctivitis, they do help in the diagnosis of the snake bite and may prompt us to start the anti-snake venom, but at times, like bite by uh, crate doesn't show any local sign. It's just the local bite marks may be missed or it's just a scratch mark. So we have to see the systemic signs also, sign and symptoms also. So with these facts, we come to know that fang marks, bite pattern, snake identification, they do not contribute much towards the treatment. What matters is the clinical presentation of the patient with the snake bite. So the management of the snake bite is chiefly based on the syndromic approach. Since India does not have a commercial snake venom detection kit, doctor says they use syndromic approach to diagnose the snakebite cases. And this approach involves observing the sign and symptoms, conducting various blood tests like whole blood, 20-minute whole blood clotting time, and this helps us as a doctors to decide if the venom which has been injected is what type of is it and what type of snake bite it might be. And based on these, we start the treatment with anti-snake venom. In syndromic approach, uh, for example, this is a case of syndrome 1 where the patient may come with local swelling, bleeding disorders, and these are seen with the Vipridae family of snakes. We can see local swelling in the feet, gum bleeding, and this is the snake of Vipridae family. In syndrome 2, patient may come with local swelling, bleeding disorder, shock, renal failure, and this is especially seen with the hump nose pit viper. And if patient comes with local swelling, bleeding disorder, shock, renal failure, with ptosis, if patient comes with the ptosis, external ophthalmoplegia, facial weakness, then it is suggestive of Russell viper. And these two hump nose pit viper bites and Russell viper pit vipes pit bites, they come under syndrome 2. Similarly, patients with syndrome 3 with the bite by the cobra or king cobra, they may come with local swelling and neurological signs like ptosis, external ophthalmoplegia, facial weakness. Syndrome 4 patients usually are the cases who are bitten by crate or sea snakes. They will not have any local swelling, they may not have fang marks. They are usually bitten when they are sleeping indoors. Patient may come with ptosis, external ophthalmoplegia, facial weakness. And the syndrome 5 includes the bites by the Russell viper snakes. They may have present with dark brown urine, hemoglobinuria or myoglobinuria. They may come with renal failure, paralysis, and usually they are bitten on the land. So whenever the suspected snake bite came to us in emergency room, it can be overt bite or occult bite. The overt bite, we have to see the history of the bite. It could be non-venomous, which is seen in 70% of the cases, and venomous, which is seen in 30% of the cases. In non-venomous bites, the patient may be asymptomatic, but he can have anxiety, palpitation, tachycardia, paresthesias, and venomous snake bite cases, which include 30%, they at times may have dry bites and they may also present with anxiety, palpitation, tachycardia, and paresthesia. And these venomous snake bite, if symptomatic, then we have to judge them by the syndromic approach, that is predominantly the symptom manifestation. Like if they present with progressive painful swelling, then this could suggest us a viper bite. These patients will have local necrosis, ecchymosis, blistering, painful swelling, compartment syndrome, and we have to start anti-snake venom in these cases. These patients may present with neuroparalytic symptoms as seen with the cobra and great white. Patient will have ptosis, diplopia, dysarthria, dysphonia, dyspnea, dysphagia, paralysis. Here we have to start the anti-snake venom, atropine, neostigmine, and we have to maintain the respiratory support by proper ventilation. These patients of venomous snake bite may have vasculotoxic features, usually seen with the Russell viper or saw-scaled viper bites. Patient will have bleeding manifestation, may present with DIC, shock, acute kidney injury, and in these cases, anti-snake venom supportive treatment is required. Patient may at times require dialysis and blood transfusion. In the suspected snake bite, if present with occult bite, that is, there is no history of bite, especially it is seen with the crate. Patient may have neuroparalytic symptoms with no local signs. Patient may present with severe abdominal pain, and these patients will also have will also require anti-snake venom. Atropine neostigmine, though not very useful in crate bite, but we may prefer to give, and now they also require the ventilatory support. One thing I missed in symptomatic venomous bite is the patient may present with myotoxic features that is seen with sea snakes. Patient will have muscle aching, muscle swelling, involuntary contraction of the muscle, compartment syndrome, and these patients may also require anti-snake venom, supportive treatment, and dialysis. So this is the nutshell which I discussed in the previous slide. You can go through this. Coming to the anti-snake venom. Anti-snake venom which is used in India is polyvalent anti-snake venom. It is effective against multiple snake species as identifying the species is often impossible. No ASV for all species. Some snakes like sea snakes, green pit snakes, and others, they are not covered by the available anti-snake venom in India. This anti-snake venom comes in two forms, liquid form and lyophilized powder form. Liquid form has 2 years shelf life and it requires the proper cold chain to maintain its potency. This powdered form uh, anti-snake venom, it has a shelf life of 5 years and it requires only the cold storage. We have to use ASV with very cautiously because at times patient may have reaction and if we use it unnecessarily in non-venomous snake bites or without taking into consideration the various sign and symptom as I already discussed, then since it is costly affair, there may be wastage of the resources if used unnecessarily. We have to use it only when it is necessary, confirm the snake bite and confirm the sign and symptom, then only with lab values, then only start the anti-snake venom. As these patients at times they may show adverse reactions. Anti-snake venom which is available in India, they work against all the four big species like Indian cobra, Russell viper, common crate, saw-scaled viper, and 1 ml of anti-snake venom, it neutralizes zero point 0.6 milligram of venom of Indian cobra and Russell viper and 0.45 milligram of common crate and saw-scaled viper venom. The one vial of the anti-snake venom comes as a 10 ml ASV and it neutralizes 10 times the above amount. So average treatment requires 20 vials for the viper bite. So whenever we have to start the anti-snake venom, we have to consider these indications like patient will have fang marks or they may miss fang marks but will have local swelling, tender nodes as seen with the uh, vasculotoxic or myotoxic snake bite cases. Patient will have hemostatic abnormalities, 20-minute whole blood count and 20-minute whole blood clotting time and PTINR, deranged PTINR. Patient will have neurological signs like ptosis, ophthalmoplegia, may have hypotension, shock, arrhythmias, oliguria, elevated creatinine, elevated creatinine kinase, potassium levels, suggestive of rhabdomyolysis. So, if the patient present with these signs and symptoms and with these lab findings, we have to start the anti-snake venom. This is the table which shows the various clinical features with the different snakes, like patient with cobra bite, they may have local swelling, tissue damage, they may present with ptosis, neurological signs, but they will not have any hemostatic abnormalities. They may not have any renal complications, and they will respond to anti-snake venom and the neostigmine. Patients with great white, they will not have any local pain or tissue damage. They will have ptosis and neurological signs. They may not have hemostatic abnormalities or renal complication. They may respond to neostigmine or may not, but they respond to anti-snake venom. Patient with Russell Viper bite will have local pain, tissue damage, ptosis, neurological sign, hemostatic abnormalities, but they will have renal complications also, and they may or may not respond to neostigmine, and response to ASV is seen. Patient with saw-scaled viper and hump-nosed viper bites will have local pain and tissue damage. There will be no neurological sign. They will have hemostatic abnormalities. Renal complications are seen with the hump-nosed viper, but not with the saw-scaled viper. They will not respond to neostigmine, and patient with saw-scaled viper, they will respond to anti-snake venom, but hump-nosed viper bite have no response to anti-snake venom. While administering the anti-snake venom, we have to ensure that we give it through IV route only, and that too slowly under close supervision of a doctor. We should always keep adrenaline ready in case of any reaction. It should be filled in a syringe before giving the anti-snake venom. Don't inject adrenaline, but we have to keep ready it in an emergency tray. We have to increase the infusion rate gradually if no reaction occurs, and we have to complete the starting dose within 1 hour. Don't give anti-snake venom through a muscle, or that is intramuscular route, as it won't work well. We don't inject anti-snake venom directly into the bite wound, as it is very painful and ineffective. We have to take all sterile precaution to prevent the infections and the reactions. Coming to the preparation of anti-snake venom, we have to reconstitute anti-snake venom powder with 10 ml of distilled water. Mix it by swirling movement, not by the shaking. Check if the solution is clear, then only give. If it is opaque, don't use it. How do we prepare? Add the reconstituted anti-snake venom to the infusion bag, that is 10 vials in 100 ml of distilled water plus 400 ml of normal saline or dextrose 5%. So 10 vials of anti-snake venom, they are dissolved in 100 ml of distilled water and added to 400 ml of normal saline or 5% dextrose, and they are infused as a constant rate over 1 hour. Initial dose in saw-scaled viper is 5 vials, and in other snake bite cases it is 10 vials. We have to check for the remaining venom with 20-minute whole blood clotting test 6 hourly after the first dose. If the venom is still present, give a second dose of anti-snake venom 6 hours after the first dose. This table depicts the average dose requirement of anti-snake venom in different bites. Indian cobra may require about 100 ml of ASV, that is uh, 10 vials as an initial dose. Common crate will also require 10 vial as an initial dose. Russell vial, Russell Viper White will also require 10 vial as a initial dose, but sauce scaled Viper requires only 5 vials as initial dose. So the patient with neuroparalytic snake bite, they will require 10 vials of anti-snake venom initially, and we have to give it as a stat dose over 30 minutes. Second dose of 10 vials is given after 1 hour if there is no improvement. For vasculotoxic snake bite, we usually follow low dose infusion therapy or high dose intermittent bolus therapy. In low dose infusion therapy, 10 vials of Russell Viper, 10 vials are given for Russell Viper, or 6 vials are given for sauce scaled Viper over 30 minutes, and 2 vials every 6 hourly in 100 ml normal saline until the clotting time normalizes or for at least 3 days. In high dose intermittent bolus therapy, 10 vials of anti-snake venom is given over 30 minutes and 6 vials then 6 hourly as bolus therapy until the clotting time normalizes or there is no local swelling or local swelling subsides. Please note that there is no anti-snake venom for sea snake bite or pit viper bites. High initial doses of anti-snake venom up to 30 vials may be required for life-saving surgeries to restore the coagulation quickly. And also note that test dose is not required in while administering the ASV to a snakebite patient because it has no predictive value and it is not recommended. This we have to ensure that we have to know that this reaction to the anti-snake venom is usually a complement mediated, and the skin test we usually do is the IgE mediated, and so we may not get any result by checking the test dose because, and even we also make the patient uh, sensitive or pre-sensitize the patient, and if we inject the anti-snake venom later it can increase his greater risk for further reaction. So it is recommended that the testing dose or ASV test dose should not be done. How does the anti-snake venom works? Basically, anti-snake venom, when we inject through IV, it binds to the unbound circulating venom in the blood, lymph, and neutralizes it, and prevents further damage by stopping the venom from binding to the target cells. It does not reverse the existing damage, it does not improve the patient's condition, it does not fix the tissue necrosis, it does not reduce the local swelling, it does not reverse the kidney failure, it does not fix the blood clotting issues as the liver does, it does not reverse the nerve damage. That is, we have to see that as early as we give the anti-snake venom, it will bind with the unbound circulating venom and will prevent the further damage. Late, if we start anti-snake venom late, the damage occurred in the nerves or other tissues may not be reversible with the anti-snake venom. So start early for the better result if we are sure about the snakebite case. Some studies have shown that anti-snake venom can control swelling, but these studies are not robust. Swelling may stop due to the venom's natural progression, not just anti-snake venom. Persistent swelling may require surgical intervention, not increasing the anti-snake venom dose. Whenever we give anti-snake venom, We have to monitor the patient, watch patient closely for any reaction every 5 minutes for initial 30 minutes, then every 15 minutes for at least 2 hours. Monitor the urine output and color to detect any kidney injury. Effectiveness of the antivenom, we have to see we give antivenom as soon as possible after the bite to prevent the maximum damage. It can reverse the systemic envenoming after several days or weeks. Give antivenom as long as coagulopathy persists. Antivenom may prevent local necrosis if given within a few hours of the bite, but this is controversial. The patients, if arrives later after several days, they can come with acute kidney injury. But in these patients also, we have to check for current venom activity like bleeding, which is usually seen with piperine snake bite cases. We have to perform 20-minute whole blood clotting time to check for coagulopathy. Administer the anti-snake venom if coagulopathy is present. If no coagulopathy is present, we have to treat the kidney injury if it is present. Patients with neuroparalytic snake bite, we should give them continue respiratory support until there is complete recovery. Give 10 vials of anti-snake venom on arrival and repeat if no improvement within 1 hour. Maximum 20 vials can be given. No further anti-snake venom is required thereafter. Atropine neostigmine infusion is required only to reverse the ptosis. Ptosis is common. Ptosis in common crate bite is due to presynaptic blockage, and further ASV and neostigmine does sorry further ASV and neostigmine dose beyond 3 doses cannot reverse it. Since regeneration is a natural process, it may take 4 to 5 days. Stop anti-snake venom and atropine neostigmine when pharyngeal muscle palsy is resolved. Remember that timely treatment is crucial, and also be mindful of unnecessarily additional treatment. Anti-snake bite and anti-snake venom and pregnancy. Limited research is available that snake bites during pregnancy is rare. It is unclear if snake venom or anti-snake venom crosses the placenta. Snake bite does not always lead to spontaneous abortion. Only 30% uh, abortions are seen in one study. The treatment for snake bite in pregnancy is same as of non-pregnant victims. The dose of anti-snake venom is same dose and under the same criteria as non-pregnant victims. It has been seen that good maternal outcomes are seen when ASV is given. The risk of snake bite are greater during the first trimester. Systemic toxicity, especially with bleeding and coagulopathy, poses a higher risk. We should always refer the patients in first trimester with systemic signs to a gynecologist for specialized treatment or review. Abortion, if it occurs, it usually happens within 7 days of the bite. Children also require the same dose of ASV as seen in adults. We have to give diluted form, and we have to dilute anti-snake venom in 5 to 10 ml per kg body weight of normal saline and reduce fluid volume in running bottle to 200 ml to avoid the fluid overload in children. If patient with repeat bite comes to us, though repeat bites are rare, but they carry a slight increased risk of adverse reaction. Same dosage schedule applies for the repeat bite also. We have to consider the prophylactic adrenaline regimen if concerned about the adverse reaction and handle any reaction as usual. After the initial dosing, repeat dosing is also required for vasculotoxic or hemotoxic envenomation. We have to repeat the clotting test every 6 hourly until the coagulation is restored. Give anti-snake venom every 6 hourly until coagulation is restored. For hump-nosed pit viper envenomation, here the anti-snake venom may not work and coagulopathy can last up to 3 weeks. If 30 vials of ASV have been administered, reconsider whether the continuing administration of anti-snake venom will solve any purpose, particularly in the absence of proven systemic bleeding. In cases of neuroparalytic or neurotoxic envenomation, repeat the anti-snake venom if neurotoxic or cardiovascular sign worsen over 1 to 2 hours. Maximum dose is 20 vial of anti-snake venom. If large doses have been administered and the coagulopathy still persists, we can think of giving fresh frozen plasma, cryoprecipitates of fibrinogen and factor 7. We can give fresh whole blood if fresh frozen plasma is not available, and we can give platelet concentrate also. Response to ASV. The patient responds. If patient responds to anti-snake venom, the patient will feel better. Nausea, headache, and generalized pains, they may disappear very quickly. Patients with systemic bleeding, for example from the gums, that may stop within 15 to 30 minutes. Blood coagulation profile as measured by 20-minute whole blood clotting time, usually restored in 3 to 9 hours. Bleeding from new and partly healed wounds usually stop much sooner than this. In patients with shock, blood pressure may increase within first 30 to 60 minutes, and arrhythmias such as sinus bradycardia may resolve. Patients with neurotoxic poisoning like by the postsynaptic bite with the cobra, they may begin to improve as early as 30 minutes after the ASV, but it may usually take several hours. Patients with presynaptic toxin like crate and sea snake, they may not respond in this way. Patients with active hemolysis and rhabdomyolysis may cease within few hours and the urine returns to its normal. And in patients who are bitten by the vipers after the initial response to antivenom, the bleeding restoration of blood coagulability and signs of systemic inflammation may respond within 24 to 48 hours. Coming to the specific bites, in case of neurotoxic snake bite, after giving the initial anti-snake venom, these patients usually presents with neurotoxicity in the form of ptosis or inability to maintain upward gaze. In these cases, the atropine neostigmine challenge test is administered. Here we give them neostigmine or atropinium after giving the anti-snake venom. So always remember that first we have to give anti-snake venom. Then if they have these neurological signs like ptosis, we give atropine 0.6 mg IV. In children dose is 0.05 mg per kg. Then after giving atropine, we give neostigmine 1.5 mg IV as a stat dose, or atropinium can be given as 10 mg IV. If the objective improvement is not seen after 5 minutes, repeat the dose of neostigmine 0.5 mg with atropine every 30 minutes for 5 doses. In children, the atropine dose is 0.05 mg per kg followed by injection neostigmine 0.04 mg per kg intravenous, and repeat the dose of 0.01 mg per kg every 30 minutes for 5 doses. A fixed dose combination of neostigmine and glycopyrrolate IV can also be used. Neostigmine is an anticholinesterase that prolongs the life of acetylcholine and can therefore reverse the respiratory failure and neurotoxic symptoms. It is particularly effective in postsynaptic neurotoxins such as those of cobra, and it is not useful against presynaptic neurotoxin, that is bite by the great and Russell viper. Thereafter, we have to give it as a tapering dose of at 1 hour, 2 hour, 6 hour and 12 hour. Majority of the patient improve within first 5 doses. Observe the patient closely for 1 hour to determine if the neostigmine is effective. After 30 minutes, any improvement should be visible by improvement in ptosis. Positive response to atropine neostigmine trial is measured as 50% or more recovery of the ptosis in 1 hour. Stop atropine neostigmine dosage if patient has complete recovery from the neuroparalysis. Rarely the patient may have recurrence. Carefully watch the patient for recurrence. Stop it if the patient shows side effects in the form of fasciculation or bradycardia. Stop the atropine neostigmine if there is no improvement after 3 doses. Improvement by atropine neostigmine indicates cobra bite. A few Nilgiri Russell viper bites victim also improve with this regimen. Give 1 dose of atropine neostigmine injection before transferring the patient to higher center because rapid deterioration of the cobra bite may kill the patient on the way to the transfer. If there is no improvement after 3 doses of atropine within 1 hour, this indicates probable crate bite, and crate affects presynaptic fibers where calcium ions act as a neurotransmitter. In these patients, give injection calcium gluconate 10 ml slowly over 5 to 10 minutes every 6 hourly and continue till neuroparalysis recovers, which may last for 5 to 7 days. A trial of anticholinesterase test should be performed in every patient with neurotoxic envenoming as it would be in any patient with suspected myasthenia gravis. However, this should not delay the antivenom treatment or endotracheal intubation. Patient must be observed closely as they may deteriorate while the trial of anticholinesterase is being carried out. Some authors have suggested that it may be possible to treat the patient with anticholinesterase drugs solely in the cases of elapid bites. However, this approach ignores the values of neutralizing the free-flowing venom before it can attach and require reversing. Anticholinesterase drugs being used as a substitute for anti-snake venom should only be considered if no ASV is available. The more venom that can be neutralized before it binds to the target receptors and reduces the severity of toxicity. In case of cobra bite, if the patient attends a small center where indoor admission facility is not available, 1 dose of AN injection, atropine neostigmine injection, should be given before transferring the patient to the next higher center. Rapid deterioration of cobra bite neurotoxic syndrome may kill the patient on the way to transfer, and this is applicable in emergency ambulance services also. Patients with neurotoxic snake bite, they may come as unconscious and their death can occur from aspiration, airway obstruction, respiratory failure. So maintaining breathing is very crucial for survival. We have to transfer from initial medical contact to advanced hospital with proper airway support or mechanical support. Airway management is very crucial in these patients. We have to maintain the clear airway. We have to insert the cuffed endotracheal tube or laryngeal mask if there is loss of gag reflex, pulling of the secretions in the pharynx, if there is failure of the cuff reflex, and if the patient is in respiratory distress. Perform tracheostomy if intubation is impossible. The medical officers in the rural health center must be trained in endotracheal intubation and ambulances and rural health center must stock LMA. Importance of airway support is that antivenom alone is insufficient for treatment. Patient may die from asphyxiation without airway support. We have to refer the patient to better equipped hospital if unable to perform the neck lift. Provide the airway support during transfer as the respiratory failure can occur during the journey also. How do we give airway support? We have to use the resuscitation bag. Place the mask over the nose and mouth. Hold the mask with the CE grip, that is thumb and index finger on the top and other fingers under the jaw. Squeeze the bag as a squeeze release rhythm. Limitation of using resuscitation bag in neurotoxic envenomation. Respiratory failure can occur due to flaccid paralysis. Tongue may fall back and obstruct the airway, limiting the resuscitation bag effectiveness. So, nasopharyngeal airway support is required. Insert the nasopharyngeal airway before transport to increase the respiratory support. If NPA is not available, improvise nasopharyngeal tube from endotracheal tube. Here we use 6.5 ET tubes for female, size 7 for male, or size 5 for either. Cut the tubes to the distance between the nostril and the tragus. Lubricate and insert the tube into the nostril. Cut the correct length to avoid triggering of the cut the correct length to avoid triggering the gagging reflex. Insert the tube. The patient cannot perform a neck lift and transfer the patient to higher center. Instruct accompanying individual to use the resuscitation bag if the patient stops breathing. These breathing devices they improve the airway support. Airway breathing devices we can use as laryngeal tubes or laryngeal mask airway for excellent airway support. They are easy to use. They are inserted blindly. They have a high success rate, making them suitable for use by non-medical personnel during transport. The laryngeal tubes they are preferred over LMA due to their ability to create a better seal, especially during the rough transport. Endotracheal intubation provides a definitive airway but requires equipment and expertise often unavailable in primary health centers. Mechanical ventilation long-term respiratory support is crucial but may not be available in developing countries. Breathing solutions like laryngeal tubes and laryngeal mask airway are necessary to ensure the survival during the transport in resource limited areas. Remember that airway support is crucial and critical. An improvised solution can help save lives in resource limited areas. Patients with hemotoxic envenomation they may require blood products and they may end up with renal failure. The systemic bleeding is common in viperine bites. They may come with hypotension, low HP, thrombocytopenia, frank bleeding. The causes for the hypotension are hemorrhage, vasodilation, direct venom effect on the heart. We all should always check whether there is postural drop in blood pressure. We have to timely start anti-snake venom and we have to stop the systemic bleeding. But if systemic bleeding does not stop, the further treatment is needed. Further treatment includes strict bed rest, screening for hematuria, hemoglobinuria, myoglobinuria using dipstick method, monitor the urine output. Aim of the urine output is 1 ml per kg per hour. These patients may require volume replacement. We have to ensure the IV access, preferably 2 IV access with large bore needle. We have to give fluid challenge, that is 2 liters of isotonic saline over 1 hour or until the central venous pressure rises to 8 to 10 centimeter. We have to monitor for pulmonary edema. Use of vasoconstrictor drugs like dopamine may be needed. Plasma expander is used to boost the blood volume and restore the factors. Fresh frozen plasma or factors may be needed. Fresh blood may be the only alternative in developing countries. If the patient comes with severe bleeding or have persistent bleeding, timely use of anti-snake venom will stop the systemic bleeding. However, if the bleeding is persistent, we have to consider the clotting must be established. So, but you don't add clotting factors too soon. If the venom is still present, adding clotting factors, fresh frozen plasma, cryoprecipitate, or whole blood can harm the kidney function. Role of anticoagulant. Heparin is not useful despite the intuition that heparin doesn't work for snakebite induced bleeding and can even cause more harm. Coagulants they can't stop bleeding. Drugs like petropase derived from the snake venom can worsen the bleeding by prolonging the coagulation problems. Don't use heparin as it is ineffective and can cause bleeding. Don't use antifibrinolytic agents, they are not effective. Coagulants like petropase they can worsen the bleeding. Patients with hemotoxic snake bites they will have dangers of venipunctures. The bleeding is increased in these patients. So patients with incoagulable blood may bleed excessively from the injection sites or venipunctures or cannula insertion. We have to minimize the venipunctures, use indwelling cannula and three-way to reduce the repeated venipuncture. Heparinized saline is used to fill the dead space with heparinized saline after coagulability is restored but flush before blood sampling. Avoid the arterial puncture. It is contraindicated in patients with coagulopathy. Choose safe venous access site. Opt for areas where external pressure can control bleeding, like the antecubital fossa. Avoid jugular, subclavian, and femoral vein if possible. Avoid these areas for vein puncture. Apply pressure pad. Always apply a pressure pad at the venipuncture site. Patients with Russell Viper bites they may have long-term issues like acute pituitary adrenal insufficiency, and this condition may contribute to the shock. Follow-up are required in Russell Viper bite to ensure the long-term pituitary sequelae are not seen or they are properly managed. Renal failure is common complication with Russell Viper bites. The contributing factors are intravascular hemolysis, DIC, direct nephrotoxicity, hypotension, rhabdomyolysis. Renal damage can occur quickly even before hospital arrival, and studies have shown that even when anti-snake venom is administered within 1 to 2 hours after the bite, it was incapable of preventing the acute renal failure. And these patients, when the renal failure develops, may require dialysis, and the indications for the dialysis are if the blood urea levels are more than 130 mg per deciliter, 100 mg per deciliter, serum creatinine more than 4 mg per deciliter, or when there is evidence of hypercatabolism in the form of a daily rise in blood urea by 30 mg, rise in serum creatinine by more than 1 mg, and fall in bicarbonate by more than 2 millimole per liter. Dialysis is also indicated if there is fluid overload, including fluid overload leading to pulmonary edema, patients with hyperkalemia with ECG changes, patients who are unresponsive to the conservative management, or if the patient will present with uremic complications like encephalopathy, pericarditis, nausea, vomiting, hiccups, fetor, drowsiness, confusion, coma, flapping tremors, muscle twitchings, convulsion, pericardial friction rib, signs of fluid overload, declining renal parameters. Peritoneal dialysis should be performed in secondary care center. Hemodialysis is preferable in case of hypotension or hyperkalemia. Patients with oliguria phase of renal failure. Most but not all patients with these renal failure are oliguric Oliguria is defined as urine output less than 400 mg per day or less than 20 ml per hour. Here, the conservative management may avoid the need for dialysis. If the patient has intravascular volume depletion indicated by supine or postural drop in blood pressure or empty neck vein, we have to establish the intravenous access, give fluid challenge test, insert the catheter, and these patients may require forced alkaline diuresis. If the patient has oliguria or dipstick positive for blood, give a trial of forced alkaline diuresis within 24 hours of the first bite to avoid the pigment neuropathy leading to acute tubular necrosis. Delayed forced alkaline diuresis has no role. So, see various steps for forced alkaline diuresis is give furosemide 40 mg IV stat followed by injection normal saline 500 ml plus 20 ml of sodium bicarbonate over 20 minutes. Then give injection ringer lactate 500 ml plus 20 ml of sodium bicarbonate over 20 minutes. Then give injection 5% dextrose 500 ml plus 10 ml of potassium chloride over 90 minutes. Then give injection mannitol 150 ml over 20 minutes. Whole cycle completes in 2 or 30 minutes and urine output of 3 ml per minute is expected if the patient responds to first cycle. Continue for at least 3 cycles. The forced alkaline diuresis converts the oliguria into polyuria and avoid the acute tubular necrosis and acute kidney injury which requires dialysis in more than 75% of the patient. If there is no response to furosemide, discontinue the forced alkaline diuresis and refer the patient immediately to higher center for dialysis. If the urine output does not improve despite these challenges, no further diuretic should be given and fluid intake should be restricted to a total of previous day's output plus insensible losses. If possible, the patient should be referred to a renal center. The diet should be bland, high on calories, low protein, low in potassium, fruit juices, and low in salt. Infection will cause tissue breakdown and increase the urea level, and they should be preferably prevented or treated promptly with non-nephrotoxic antibiotics. We should always avoid the aminoglycosides such as gentamicin. Biochemical monitoring, serum potassium, urea, creatinine, and if possible pH, bicarbonate, calcium, phosphate should be monitored frequently. And if this is not possible, then send the patient to higher center and maintain the ECG. It should be examined for evidence of hyperkalemia, especially following the bites by the sea snakes or Sri Lankan South Indian Russell viper, or if the patient is passing dark urine, which indicates rhabdomyolysis or intravascular hemolysis. If the patient is detected with hyperkalemia as evident by the ECG findings, that is stalled peak T wave, prolonged PR interval, absent P waves, wide QRS, emergency treatment with of hyperkalemia within 3 to 6 hours should be done, and these patients should not be given serum potassium. Emergency treatment should be given if the patients have hyperkalemia and ECG changes. For hyperkalemia, give 10 ml of 10% calcium gluconate intravenously over 2 minutes with ECG monitoring if possible. Repeat the dose up to 3 times. GI drip can be given, glucose insulin drip. Give 50 ml of 52% dextrose with 10 units of soluble insulin intravenously. Sodium bicarbonate 40 ml of 8.4% by slow intravenous infusion. Beta 2 agonist aerosol by inhaler. Salbutamol inhalation may also be used. Management of severe acidosis if the patient is hypotensive and profoundly acidotic, very low plasma bicarbonate concentration, sodium bicarbonate should be given, and based on the volume of distribution of bicarbonate, which is 40% of the body weight, bicarbonate deficit may be calculated, and usually 2 to 3 ampules of 40 ml of 8.4% sodium bicarbonate in 5% dextrose water or half the calculated deficit can be replaced within 3 to 4 hours. Severe acidosis in snakebite is usually associated with acute renal failure. Volume expansion by sodium bicarbonate can cause fluid overload, and if there is no clinical improvement, dialysis is required. Intravenous bicarbonate may precipitate profound hypocalcemia and fit, especially in patients with hypocalcemia. Indications for dialysis are I have already discussed. Long-term effects of the Russell Viper bites may have diuretic renal failure that may last for months after the bite. Hypopituitarism is very common with the Russell Viper bite. Some patients may experience ongoing kidney damage, albuminuria, hypertension, nocturia, bilateral renal cortical. Bilateral renal cortical necrosis may requiring dialysis or transplantation. Chronic kidney dysfunction. Some patients may develop chronic kidney disease requiring dialysis or transplantations. Patchy cortical necrosis may lead to delayed and partial recovery, while diffused cortical necrosis require regular dialysis and eventually transplantation. Pain and wound management and surgical aspect of snake bite. Snake bite is painful. The action of spreading vectors and tissue damaging toxin in the venom can cause significant pain at the bite site and in the bitten limb. Pain relief is vital but often overlooked aspect of the snake bite management. The drug of choice is paracetamol. Adult dose of 500 ml to 1 gram 4 to 6 hourly can be given. In if available, mild opiate such as tramadol 50 mg can be given orally for relief of severe pain. In case of severe pain at the tertiary center, tramadol IV can be given. Aspirin should not be used due to its adverse effects on the hemostasis due to inhibition of the platelet aggregation. Do not use non-steroidal anti-inflammatory drugs as they can cause bleeding. This can be particularly dangerous in patients having coagulopathy. Antibiotics and tetanus toxoid. There is no routine use of antibiotics in snake bites. Exceptions are there if the bites are with a certain snakes like Malian pit viper, Chinese cobra, and if the wound cutting has been attempted by some locals or patient himself, or if there is necrosis, or we are suspecting wound infection, then we can think of giving the antibiotic, and we can give oral levofloxacin and amoxicillin globulin combination can be given. We can give prophylactic broad spectrum antimicrobial treatment for cellulitis after completion of first 10 vials of anti-snake venom. Tetanus, if patient is not immunized already, he should be given tetanus, although these can be delayed until coagulation is restored in cases with incoagulable blood. In many areas where tetanus inoculation will not be thorough, tetanus toxoid should be given. Patients with snake bite may have ophthalmic features also. Sometimes Najakothia venom has spat into the eyes of the careless snake handler while handling the snake, holding it close to the face. This venom is directed in the eyes and causes extreme pain and conjunctivitis. And in such patients, urgent decontamination of the copious irrigation with drinking water is required. Instill topical 0.5% adrenaline in the eye. Topical administration of the local anesthetics like tetracaine or proparacaine, excluding the corneal aberration by fluorescein staining with slit lamp examination, and application of prophylactic topical antibiotic like moxiflox eye drop 6 times per day is also recommended. Prevent the posterior synecdoche or ciliary spasm and discomfort with topical cycloplegics. Antihistaminic are used in case of allergic keratoconjunctivitis. Surgery and the snake bite. Surgical intervention, they are used with very caution only when necessary. Life-saving procedures and removal of necrotic tissue may be required. referred to the surgeon after antivenom treatment is completed. Surgery is usually required when there are intracranial bleeds and surgical intervention is required to remove the clot and relieve the pressure. Coagulation must be restored rapidly with large initial dose of anti-snake venom. Debridement of the necrotic tissues. Wait for 5 to 7 days to determine the viable and non-viable tissues. The key principles are: restore the coagulation quickly within 6 hours to enable life-saving surgery, keep the necrotic areas clean and apply topical agents, refer the patient to the facilities for surgical capability or hard tertiary care centers. Compartment syndrome. Compartment syndrome and snake bite. It is basically a swollen, cold, pulseless limb. It may suggest compartment syndrome. Swelling the tight muscle compartments can cause tissue pressure to rise, leading to ischemia. Classical signs of compartment syndrome may be hard to detect in snake bite victims. Patient may present with severe pain, weakness in the affected muscles, pain when stretching affected muscles, numbness and tingling in the affected skin, tense compartment on palpitation. The 6 P's are pain on passive stretching, pain out of proportion, pulselessness, pallor, paresthesias, paralysis. Fasciotomy is performed only if intracompartmental pressure is very high enough to cause blood vessels to collapse. Measure the pressure directly. Fasciotomy does not remove or reduces the embolization. Criteria for the fasciotomy in snakebite cases are: please ensure that hemostatic abnormalities have been corrected with antivenom or without clotting factor, and there is clinical evidence of intracompartmental syndrome, intracompartmental pressure more than 40 mm of mercury in adults. Early treatment with antivenom remains the best way of preventing the irreversible muscle damage. There is a little objective evidence that intracompartmental pressure due to snake bite in India ever reaches the prescribed limit for a fasciotomy. Very limited trial data has tended to confirm this. In any case, fasciotomy should not be contemplated until the hemostatic abnormalities have been corrected. Otherwise, the patient may bleed to death. Not only in the reversing coagulopathy, antivenom may also be helpful in reducing the severe limb edema. Level of evidence, however, corticosteroids are not effective in reducing the local effects of envenoming since they carry the risk of side effects and they should not be used. The patient should be referred to a surgical specialist, but it is worth for treating clinician ensuring that objective criteria used to assess the actual intracompartment pressure in the limb. The limb can be raised in the initial stages to see if the swelling is reduced. However, this is controversial as there is no trial evidence to support the effectiveness. Persistent moderate swelling of the limb after viper bite can be successfully managed by systemic broad spectrum antibiotic and repeated magnesium sulfate compresses in the layers of a wet bandage changed every 2 to 3 times a day for 5 to 7 days. The conservative treatment when no antivenom is available. The conservative measures are: for neurotoxic envenoming with respiratory paralysis, assisted ventilation with room air or oxygen, manual ventilation, for example, with anesthetic bag if no mechanical ventilator is available. For hemostatic abnormalities, strict bed rest to avoid trauma, transfusion of the clotting factors, platelets, fresh frozen plasma. For patients with shock and myocardial damage, the correction of hypovolemia with colloid and crystalloid. Use pressure drugs like dopamine, epinephrine, adrenaline if needed. Treat the hypotension with bradycardia using atropine. Patients with acute kidney injury, they require the conservative treatment or dialysis. Patients with myoglobin or hemoglobin urea, we have to correct the hypovolemia with IV fluid, correct the acidosis with sodium bicarbonate, consider mannitol infusion one time only. Patient with severe local envenoming, the surgical intervention may be needed but consider the risk. prophylactic antimicrobial treatment is justified. If no symptoms are seen after 24 hours, we can discharge the patient. Observe for at least 48 hours if the antivenom was given. Follow-up of the snake bite cases. Advise the patient to return if the symptom worsen. Explain the signs of serum sickness like fever, joint pain, etc. Rehabilitation of the limb is maintain limb in functional position. Start simple exercises in the hospital. Continue rehabilitation at home with relatives' help. Conventional physiotherapy may accelerate the recovery. Coming to the adverse anti-snake venom reactions, early reactions are seen within 10 to 180 minutes after treatment in the form of itching, hives, dry cough, nausea and vomiting, abdominal pain, diarrhea, fast heart rate, fever. Patient may have severe reaction in the form of low blood pressure, hypotension, difficulty in breathing, swelling of the face, eyes and tongue. Monitor for any new symptom after starting the anti-snake venom, that is, look for vomiting, sudden cough, abdominal pain, shortness of breath, drop in blood pressure, swelling of the face and the eyes. Adverse reaction to anti-snake venom are two types. First is the pyrogenic reaction, which occurs within 1 to 2 hours after the treatment in the form of chills, rigors, fever, low blood pressure caused by the contamination with pyrogens during the manufacturing. Second is the late or serum sickness type reaction, which usually seen within 1 to 12 days after the treatment and average 7 days. Patient may have fever, nausea, vomiting, diarrhea, itching, urticaria, joint and muscle pain, lymph node enlargement, and rarely kidney damage or encephalopathy. Mechanism of reaction in these cases is usually not understood. It is possibly due to ASV protein directly activating the complement system, immune complex formation triggering the complement activation. There is no way to predict the adverse reaction. Testing for antivenom reaction, it is not predictive, it is just the waste of time. It may even increase the risk of severe reaction when full dose of ASV is given. So skin tests are not useful for predicting the ASV reaction. They only detect the IgE-mediated allergies, which are not the main cause of ASV reaction. Most ASV reactions are caused by direct complement activation, not IgE-mediated hypersensitivity. Treatment of adverse reactions. ASV reactions are straightforward to manage if they are identified early. They are treated immediately. They are treated with drug of choice. The correct mode of administration of the drug is used. Correct reassessment period is used. Step 1 is the identification of the early reaction. Many reactions may go unnoticed if not actively looked for. Local experience can help establish the average time of reaction to start is 20 minutes for Indian anti-snake venom. Key periods is to closely monitor the patient, especially the trunk area where the reaction often first appear. Use a flashlight across the trunk to help to spot urticaria or hives. Second step is act fast. Stop ASV at first sign of reaction like urticaria, itching, restlessness, vomiting. Watch for other symptoms like difficulty in breathing, swelling, and shock. Give medication like epinephrine 0.5 mg intramuscularly for adults, and for children it is 0.01 mg per kg. Chlorpheniramine maleate 10 mg can be given intravenously, administered quickly and correctly. Speed is crucial in managing the anti-snake venom reaction. Give adrenaline intramuscular over the deadline muscle for fastest effect, that is within 8 minutes the effect is seen with intramuscular route. Avoid subcutaneous route because it takes 34 minutes for venom to reach the systemic circulation. In severe cases, IV adrenaline can be used, but with caution and medical supervision. Monitoring and the reassess. After first adrenaline dose, monitor the patient closely. Check for improvement after 5 to 7 minutes. If no improvement or worsening, give a second dose. Rarely a third dose is required. Additional medication like promethazine, chlorpheniramine, maleate, hydrocortisone can be given. And once the patient recovers, restart the anti-snake venom slowly over a period of 10 to 15 minutes under close observation and resume the normal drip rate. How to treat the late serum sickness reaction? Use oral steroid like prednisolone 5 mg 6 hourly We can add oral anti-1 histamines for symptomatic relief. Contraindications for the antivenom: absolutely no contraindication, but we have to use it with very caution in patients who have fast reaction to horse or sheep serum, and those with severe atopic disease like asthma. High risk patients should only receive antivenom if they show signs of systemic envenomy. Pre-treatment for high-risk patients includes give hydrocortisone 200 mg and chlorpheniramine before antivenom. Keep epinephrine handy, but don't give it routinely due to potential risks. Consider inhaled salbutamol for anti-asthmatic patients to prevent the bronchospasm. So pre-medication involves giving hydrocortisone, adrenaline 0.5 ml, and promethazone caps can be given. Steps of diluting the anti-snake venoms are: dilute 1 ml of anti-snake venom in vial with 10 ml of normal saline. It is solution A. Now 1 ml of solution A, mix it with 9 ml of solution 9 ml of saline. It is solution B. Its dilution is 1 is to 10. 1 ml of solution B with 9 ml of saline. Now the solution becomes solution C. Dilution is 1 is to 100. 1 ml of solution C plus 9 ml of solution C. Dilution is 1 is to 1000. Total, this is solution D. 1 ml of solution D plus 9 ml of solution, it becomes dilution becomes 1 is to 10 to 1000 is a solution E. Inject 0.1 ml of solution E IV. Watch for anaphylaxis for 15 minutes. If no reaction, inject 1 ml of solution E. Watch for anaphylaxis reaction for 15 minutes. If no reaction, inject entire solution of E. Watch for anaphylaxis for 15 minutes. If no reaction, after solution E is injected, continue the same process as follows for other solution in following sequence: solution D, followed by solution C, followed by solution B, and solution A, and then full dose. This is for patient with high risk group. How to we dilute the solution and give as per the step I mentioned. Facts to be remembered while administering the ASV. It is just a summary slide. ASV comes in liquid or lyophilized form in 10 ml vials or ampules. Store liquid ASV in a cold chain system. No dose adjustment is needed for children. Check the ASV vials or ampule status before use. Ask about prior ASV exposure. Treat the repeat case with caution. Ensure anaphylaxis management agents are available before administering the anti-snake venom. No test dose is needed. Anaphylactic reactions can't be predicted. Give ASV early to neutralize the unbound venom. Don't delay or deny ASV due to anaphylactic risk. Only give ASV to the patient showing signs of envenomations. Administer the ASV slowly by IV infusion over 1 hour. Avoid local ASV administration near the bite site. It is ineffective and painful. Snake safety tips: use a flashlight when walking in the dark. Avoid sleeping on the ground. Use a mosquito net. Keep your home clean. Store animal feed proper. Remove the rubbish around the houses or your workplace. When hiking, wear boots and long pants. Stay on the trails. Avoid long grasses and brushes. Never touch or disturb a snake. Be careful when moving rocks or debris. Always hike with a buddy. With this, I conclude my snake bite management for doctors and paramedics. Luanda Grazet has said, medicine is only for those who cannot imagine doing anything else. Thank you. Keep learning.